Hi, welcome to Guts and Glory, the podcast which delves deep into the complex world of gastrointestinal and HPB disorders. Join me every month, wherein we unravel the mysteries of these complex issues in candid conversations with leading experts who share their experiences, tackle contentious topics, and provide cutting edge insights. I'm Sadiq Sikora, and this is Guts and Glory. Today's guest is a special one. Uh, the guest is Professor T D Yadav. He is professor of GI, HPB, and liver transplant at the prestigious PGIMER at Chandigarh. TD, as we fondly call him, he's a great teacher, which we have known over all these years. He's popular amongst his peers because of the fact that he speaks his mind. TD and I go back a long way. We've been colleagues, we are friends, and we share a rare camaraderie. So, welcome, Dr. TD Yadav, on this podcast. It's a pleasure to have you on this podcast, and we'll be talking about something which is dear to you.
Thank you, sir, and uh, very good afternoon. So, no words to express my feelings. I'm so happy and getting emotional.
Let me just tell people that you're the product of Allahabad, but
Yes,
from what I understand is your Karm Bhumi
yes,
is
sir.
Lucknow
Yes,
and
sir.
then PGI Chandigarh.
Yes, sir.
So tell us a little bit about how you did that journey from Allahabad to PGI
But
Chandigarh.
during MBBS, slowly I watched our head of the department that time, late Sri Dr. ND Tehaliani, and he was a person who is, I cannot imagine more knowledgeable and sincere person than him. And he will come on time and dedicate his whole time to the teaching our patient, nothing else. And I was posted with Dr. ND Tehaliani initial few months as a first year resident. We was there, but the question was gallbladder cancer. When you used to see a gallbladder cancer patient, obviously Allahabad is a belt, Banaras, Allahabad.
Yes.
Then every patient will be either they will say they will crack a joke also. Ganges water three times a
Mm,
day and
mm,
send home. Or
mm.
then suddenly somebody will say send it to SGPGI. So I thought we should go to SGPGI, see why we are our teacher are not operating many things. And then I appeared in the exam and somehow qualified. And I think you were out of India at that time when I joined.
So
Uh,
tell me, TD, gallbladder cancer, such dismal outcome. Most patients come in advanced stages. Very often, as you said, that we try to give them just palliative care or a bad news to the family and the patient. How did you go and pursue that? Uh, in contrast to many other things which were there.
Sir, it's gallbladder cancer. To me, it seems still a challenge. Still, we have to face the challenges where we are not able to understand how to go about that. This is one area where lots of things still needs to be done. So
Yes.
many things have been done, but still lots of things has to be done in this space.
And because we all were working at that time in an area where it is almost endemic in that area, gallbladder cancers, the whole Ganges belt. So naturally, most of us would get drawn to it. So I can understand that. So, you know, I want to go step by step in this in terms of that if you have a patient who's suspected to have gallbladder cancer on imaging with stones and this mass in the gallbladder, and there is a very high degree of suspicion. How should we do the best cost effective evaluation in this scenario to understand what we can do for this patient?
So, sir, there are, I think, two types of patient when gallbladder cancer patient. One is that there is diagnosis is almost clear that there is a mass lesion in the gallbladder, and on ultrasound, ultrasonologist say that the liver is infiltrated, and then probably some lymph nodes also. So here
Yes.
is little bit easier to approach. The second group is that there is a thickening in the gallbladder, some focal thickening, which we call every time, or some circumferential thickening, or some irregular thickening, but not that clear-cut gallbladder cancer patient, which is also very challenging. I think
Yeah.
most challenging is this group area. Please do one ultrasound, GB rats, and if he suggests, then we immediately try to do as fast as possible, even in PGI, get a good contrast enhanced CT scan.
Okay.
And yes, sir. Then after the CT scan, we try to see the gallbladder, we try to see the thickening or any polypoidal lesion, if it is enhancing or not enhancing. Then try to go in the area of the draining lymph node area, like hepatoduodenal ligament, celiac axis, aortocollar group of lymph nodes. If there is any other suggestion of distance, then all the things we evaluate on CT scan. And if CT scan also suggests that it looks like a gallbladder cancer based on the whatever ultrasound, history, examination, ultrasound, and CT scan.
If there is a very high suggestion that there is malignancy on initial ultrasound, you would get a CT
Yes.
and a PET CT in all, or CT and depending on the extent of disease, a PET CT.
Sir, with experience, we go for both in all the
So you recommend doing a PET CT in all. So
all
just for
patients.
information, that in say if you do 100 PET CTs of patients with gallbladder cancer suspected or detected, how many would show metastasis on PET CT?
15 to 20% of our patient would have metastasis. And most important areas are, sir, lymph nodal area, which is aortocollar group of lymph nodes, some peritoneal this thing, and peritoneal deposits in the pelvis, and lymph nodes, distant lymph nodes, and we have found also in some these supraclavicular group of lymph nodes, which were not suggested on the clinical routine clinical examination. So
Right. So, I mean, I can understand that PET CT is important because it's an aggressive disease and you would want to not want to unnecessarily do anything if there is metastasis. The second point which I want to, talk about is, and which is often debated, is when should you do a biopsy? So, is biopsy always required? And if you have to do, how you would prefer doing a biopsy? When and how?
again, I would divide here in two groups, sir. One is that distant metastasis. Suppose there is supraclavicular group of lymph nodes on PET scan, which was not clinically palpable, or any other area which is distant area, not the drainage area of the gallbladder. Then we would like to have a ultrasound or PET guided biopsy (FNA), because then they tell the patient that only chemotherapy is the possible. Second group would be celiac group of lymph nodes, aortocoel group of lymph nodes, which is in the aortocal group of lymph nodes, if it is significant on CT scan, and also this is PET scan also suggests that it's a high chance of malignancy, then we request our colleagues in medical gastroenterology department to get a US guided FNA. Celiac group of lymph nodes, where we see what is the size of lymph nodes. Then also we try to assess the load in the hepatoduodenal ligament of the nodal load. And if load is high, if lymph node around the pancreas and around the portal vein is many, and if there is a big lymph node, and if there is celiac group of lymph node, then again we are nowadays thinking about neoadjuvant therapy rather than going into operation. So again, this group of patient would like to have FNA. Don't try to touch the gallbladder. Try to take the FNA from the area which are these area. And we request our radiologist colleague, please don't do FNA from the gallbladder. Rarely we ask for the gallbladder FNA from the lesion in the gallbladder.
So, if I summarize it, that don't biopsy resectable lesions.
Yes, sir.
If there are suggestions that there is locally advanced with nodal disease, which is bulky and distant, then target those nodes by either endoscopic ultrasound or a CT or PET CT guided biopsy. So
Yes.
I think that's a very important message because uh, we don't want to touch the gallbladder unless it is absolutely warranted in order to get the biopsy. So I'm glad we got that out of the way. Uh, the other thing in gallbladder cancer, which is often debated and talked a lot about, which is that what is the most optimal surgical procedure in patients with gallbladder cancer, especially with respect to how much liver to remove, how much extent of lymphadenectomy we have to do, and whether the bile duct needs to be resected or not. So, I want you to give some insight into this, that 2 centimeter wedge versus a bisegmentectomy, extended right hepatectomy. Which one and how do you decide what is optimal for a
I think
patient?
as a protocol, we do staging laparoscopy and maybe probably do cauterization and try to take the autocolor group of lymph node sampling. After
Yeah.
that, if everything is fine, we go try to open the abdomen again, try to look at the lymph node, distant lymph nodes, and from there, if it is okay, there are again here two groups. To your finger, if it is looking like hard, firm to hard malignant, then we send for frozen and wait. If it is just looking like little bit enlarged lymph node, but clinically doesn't look like it is malignant, so we just take the sample and keep on proceeding toward the surgery. Lymphadenectomy, which starts from the common hepatic artery coming right side, and then left hepatic artery, right hepatic artery, lymphatic tissue around the vessel, going around the periportal area, and then in between hepatic artery and portal vein, all these lymphatic tissue systematically are removed, and total the vessel, artery and vein, vessel and vein, vessel means artery, vein and bile duct also. They are denuded from all around, looped, and then we wait for the frozen section. If some frozen section suggests that there is a involvement of the cystic duct margin, then we try to cystic duct.
Let's get the lymphadenectomy out of the way. So, as far as lymphadenectomy is concerned, you would want to do the hepatic artery, the hepatoduodenal ligament, which is 12A, B, and
Yes,
P, and V, and all the hepatoduodenal ligament, and then retropancreatic nodes,
yes.
all this here. So this is the extent of lymphadenectomy you would want to do. Anything about the minimal number of lymph nodes? Is it anything important? Do you
Sir,
think?
with that time you don't count. We just take everything out. We don't go by
No,
the
no,
number.
we don't
Numbers are
count.
given. Yes, sir.
But do you think that is it important in
It's
pathology,
important.
the number of lymph
Yes.
nodes, which and
Numbers are
does it
important.
make a difference in
Yes,
terms
yes, sir.
of
Number is important. One is that adequacy of the lymphadenectomy. Second is if number comes, the ratio of the lymph node involvement will decide the future prognosis. So it's
over a period, we have realized that lymphadenectomy is the key
yes,
in
sir.
gallbladder cancer, like in many other cancers. In your experience at PGI Chandigarh and all, how often do you think we need to resect the bile duct in
Bile
a
duct
gallbladder?
resections are in a fundus and body tumors almost never required. Until unless you are finding a papillary tumor. We have not found mostly cystic duct margin coming positive. When there is a tumor at the neck and a tumor is going close to the common bile duct, and sometimes it is a supra cystic adhered also to the common bile duct tumor, then obviously CBD has to be resected. Sometimes there is a lymph node which is densely adhered behind the bile duct, and very difficult to pick the lymph node and make it oncological principle without breaching oncological principle, difficult to resect. Then very rarely CBD excision has been done. A papillary tumor, when you are, that is also
Yeah.
theoretical, very theoretical. We have not received many.
Not often, isn't it?
Yeah, yes,
This is in contrast to what Professor Miyazaki from
yes,
Japan talks
yes,
about, that because of the perineural invasion and all, he chooses to resect the bile duct in
yes, sir.
all cases. But I don't think
Beyond.
that's something which is accepted across the world? How much liver to resect? Always bisegmentectomy, always wedge, or selective? And how do you select?
Sir, it's mainly depends on, I take it like that. It depends on the location of the tumor. So if you see the gallbladder draining the portal vein, portal drainage of the gallbladder and different textbooks and some Japanese literature, that from neck and toward the common bile duct, the drainage goes little bit more toward the segment 4. Body and fundus is going toward the 5 and 8 and 6. So there are two types of drainage, and usually our philosophy is, if there is a tumor which is much more toward the neck, even if there is a cystic duct where the margin is free, then we try to go anatomical. In the beginning, we used to be more anatomical resection, but later on, because of the literature, we are little bit more conservative now. So, if there is a neck tumor, usually segment 4 resection is we do go for anatomical. But if it is a tumor which is confined to the gallbladder and infiltrating the liver, then there is a lots of literature suggests that we should go for a segment 2 centimeter margin, 2.5 centimeter margin, and all around the gallbladder, and that is enough. Usually, like taking more liver has not benefited in terms of recurrence and improving the survival. Second, you said about right hepatectomy. Usually, in a huge tumor infiltrating that area, and which on CT scan suggests that something is required, or there is a right hepatic artery involved without even jaundice, or there is a tumor which has infiltrated the portal vein. So it's a very rare. Three patients we have resected without jaundice of the locally advanced gallbladder cancer. Nowadays, we are very careful. If tumor is too big and on CT scan we are finding it is going to segment 8 or segment 7, then we go for neoadjuvant therapy. And rather than going and resecting them, because recurrence rate, even if you get R0 resection, recurrence rate is very high in gallbladder cancer.
So, tell me, since you are in this field, is the debate settled about bisegmentectomy versus a wedge of 2 centimeter?
It's not settled, sir. I don't think it's settled because, but only thing is that I used to think that if you take the a little bit more margin, then probably you are safer. And usually, until unless you are doing a bile duct resection, usually you don't have a life-threatening complication in this area. Just by increasing 0.5 centimeter, you are not going to disturb either FLR or having major resection issues. So little bit taking more rather than being conservative and going closer. My only worry is when you are going down. So when you are reaching toward the gallbladder area at the going down, then you are going closer to the cystic plate. So that should be avoided. Then 2 centimeter, 2.5 centimeter margin is enough.
It's a unending kind of
Yes.
debate, but as you said, that data doesn't say that one is better over another, but technical feasibility of one over another to get adequate clearance should be assessed. So I think the recent uh, IHPBA, APHBA guidelines, practice
Yes,
clinical
sir.
practice guidelines also suggest the same thing, and most of the data. Any thoughts on the new addition of PT2, hepatic and peritoneal, and the suggestion that for peritoneal liver resection may not be mandatory?
Sir, this Korean this thing, but I always wonder how sure we are until unless we open the gallbladder that this particular is more towards the liver. Maybe radiology, if mass lesion is not very clear cut about radiology, not clear cut, then how will on the table in a gallbladder where there is a mass lesion, we will be very sure that this is more toward the liver, less toward the this thing. I think probably people have the people who have did this study, they have done lots of intraoperative ultrasound or whatsoever I do, but I have not found is very feasible thing to, if I have opened a patient, one patient, maybe it looking like more philosophical or logical, and but not trying to address the publication. But practically, I'm not very convinced and not tried also that I go and try to look whether it is more toward the liver or less toward the liver. Once it is resectable, I think simple way is resect properly and said biopsy. Liver should be clear, lymphadenectomy should be adequate, and all other issues should be addressed properly so that patient gets justice rather than too much of in going more too much in these details might maybe sometimes harmful. But as of now, I'm not very convinced about this one. Yes.
Fair enough. Fair enough. So now we come to the more complicated situations where see a gallbladder with jaundice, that is involvement in the of the bile duct of the hepatoduodenal ligament, and then the question comes that what and to what extent the surgery should be offered and how beneficial it is and what to do for that.
First of all, sir, at the outset, we have to accept that jaundice patient gallbladder cancer, it seems it entirely different biology, because when we were in earlier our experience of jaundice patient operation was about not even reaching up to 10 to 12%. So we started looking at the extent of the common bile duct involvement, whether we can achieve by doing two segments and we can achieve a tumor-free margin. So by changing the philosophy, recent our resectability in a jaundice patient at presentation is close to 20%. So still its resection rate is too less. The question is we are nowadays, our first aim is get a good CT scan after hydration and creatinine and all, so that if we require it is comes to be resectable later on, then we should not be having stent there and then doing a CT scan. So we try to first get a good CT scan, then try to get a good MR and MRI to see the extent of the disease, whether it is going to the right duct or it is obstructing the confluence or it is going beyond that. If confluence is not involved, then it changes our philosophy of preoperative biliary drainage. Our one of our endoscopic colleague can put a stent. If confluence is involved, even our friends are not very happy to do that. And after seeing the extent of disease by doing PET scan and everything, if still it is resectable, then the same philosophy that let the jaundice come below 5 at least, even for bisegmentectomy, because sometimes we have found that right hepatic artery, though not seen on CT scan involvement, at the time of the surgery and in a jaundice patient, it becomes very difficult. So if our patient is having cholestatic liver and we are sacrificing the artery, then it might be a detrimental thing in the postoperative period. So we try to bring down the jaundice even for bisegmentectomy. Jaundice either below 5 or below 3, and then try to do a resect. However, our threshold to do a to go for neoadjuvant therapy is more in a jaundice patient having experience, more and more people having locally advanced disease or metastatic disease. So basically, we do staging laparoscopy early so that we avoid doing this. Otherwise, if patient is resectable and confluence is involved or going right side, right duct is involved, then we cannot do less than segment 4A preserving right hepatectomy. So here this patient becomes very difficult to operate, because then we have to go for a portal vein embolization, see the future laminate of the liver. So first liver get relief of the jaundice, stress-free liver, then go portal vein embolization.
So it's a difficult problem, I
Yes,
think,
sir.
jaundice and thing, and a lot of considerations. And as you said, that only about 15 to 20% would eventually come for resection. And we also don't know, and maybe you can throw light that even those who have been resected, what is their long term or what is their short term outcome even?
Our patients where everything was properly done, even in jaundice patient, if it is resectable and our margins are free, then we have observed that prognosis depends totally without jaundice patient, it is dependent on the lymph node and involvement. So if liver is thick, liver is clear, patient is tolerating that stress, and you are able to do proper resection, so then one or two or patient where I have done bisegmentectomy. I was thinking recurrence, there will be a recurrence, but recently also patient, one of the patient is coming about 3 years now, bisegmented, but the same thing. We did stented, go for neoadjuvant therapy and did a bisegmentectomy and by excision of the CBD and like this thing. So I think biologically, though it looks like they pick it for the resectability, but if you can do the proper job and patient, the problem is patient don't come for resection. Portal vein embolization, by the time patient becomes fit for the surgery, the disease becomes metastatic. So we are not putting a portal vein embolization without doing a staging laparoscopy. We 100% do, otherwise there is a resource wastage. That patient spends money even in government institute, spending money, then coming back, liver has become good, but you do a laparoscopy and there is a this thing, or you go and you are finding the lymph node which is not resectable, or you are finding vessels we are involved.
Vascular resections in gallbladder cancer. Do you think, as opposed to now in pancreatic, venous resections are acceptable? People are going towards arterial resection. Venous resection in cholangiocarcinoma is quite commonly done. But what's the status of vascular resections in gallbladder cancer, and is it worthwhile?
As a rule, gallbladder cancer, venous resection or arterial, we are not doing.
So let me get a step further. So there there are reports and there is talk about HPD, hepatopancreatic duodenectomy in gallbladder cancer, and uh, the dismal uh, behavior or outcome, immediate outcomes following this in this group of patients. So, what is your thought? Is it heroism, or is it something which ought to be done given an opportunity? And what is the outcome expected, immediate and long term, with HPD?
So, my way of looking at it at two different group of patients, sir. One is that in the pre-operative period, by doing a good CT scan, we are sure that this patient is going to require HPD to have a R0 resection. So this patient will definitely go to neoadjuvant therapy. So if required, we are not going for HPD without having neoadjuvant therapy, because we know second group of patient would be where on the table you are forced. So this group of patient prognosis in HPD, all the reports what you are talking, Japanese report, the people have not survived. 3 years survival is almost, most of the patient have got recurrence within 3 years. However, even 3 years, if it is not in the hospital, it patient is going and coming to the hospital because of the different morbidity, then that 3 years is also not acceptable. The most of our patients which we have operated are either lymph node, retropancreatic group of lymph nodes, which is not able to be resected without oncological clearance, or there is a tumor in the bile duct where margins is not able to, we are not able to achieve. For the other lymph nodes, like going toward the common hepatic artery or celiac group of lymph nodes, all any other region, extensive involvement of the duodenum, all these areas usually we refrain from doing HPD.
You have frequently alluded to the fact that neoadjuvant chemotherapy is very much in the reckoning as far as your management of advanced or locally advanced gallbladder cancer is concerned. So tell me a little more about it, because what do you use? How much time you give for this? And what are your conversions? That is conversion to resection of these patients.
We have data, sir, but conversion rate is very limited. Conversion rate is about, we did one thesis also, it about 20 to 25%. So most of the patient, they become metastatic by that time. So what I would like to tell one small story of a patient, local patient. It is 4 years now, by now. And she came to us and it was looking like resectable gallbladder cancer. So when after staging lab, I went there, so we found a autocol group of lymph nodes. I sampled, it was looking significant and it came to adenocarcinoma. I closed it. Amen. And I came out and discussed with the patient that this is a metastatic disease. Let's go for, we wish to give Gemox to this
Okay.
patient, gemcitabine and oxaliplatin. So after completing the 6th cycle, Then we get a PET scan and there is no disease on PET scan uptake. But before that also there was no disease. So it was a something like a very difficult situation. But I discussed with them. She was healthy. She is still healthy. So I said there is a chance that disease has not progressed. 6 months has passed. So should I attempt? So they said you do whatever is good for her. And we did a extended cholecystectomy. She is healthy. There is no disease recurrence. She is a more than half year, 4.5 years now. So same way, this type of aortogal group of lymph node. But since we have not yet been able to publish, so I am not talking in any forum. But there is another young man with the same problem, and his disease totally disappeared. Yeah, on the pathology specimen also there was no disease in gallbladder, not even in gallbladder, not even in hepatoduodenal ligament. And our pathologist report was that tumor was not seen. So I called our colleague that new adjuvant was given. She said, yeah, nobody has written this, so send me the report again. I will say post new adjuvant changes. And like this, I have 5 patients we have now. So I was going to suggest you have more number, then we can tell the people that aortocoel group of lymph nodes, please don't include them in the metastatic as it is in liver mets or any other metastasis.
Recently, one about 5, 7 years back, and one recently, I treated two patients.
Yes.
So one had CA gallbladder. So I explored and I found that it was infiltrating into the hilum. So I came out and I didn't proceed. He didn't have jaundice, the patient. Patient got interferon based chemotherapy at that time. This was 7, 8 years back. So
Oh,
this is what they were planning to do. And then this patient came after 6 months and there was no evidence of disease. I operated this patient and did an extended kind of cholecystectomy, and there was no tumor. This patient was on follow up till 3 years after that with no disease. After that, I have lost follow up of that. Recently, there was one patient who came with a mass in the gallbladder, which was significant size, and he was advised a extended cholecystectomy, which required would have required a extended resection. So I advised them to undergo neoadjuvant chemotherapy. He underwent neoadjuvant chemotherapy, got a good response. I operated, and there was very few cells. They said majority is necrosis, very few viable cells, and all margins and all are clear. In 1 year, this patient came back with recurrence. So, as you said, that the the outcomes are still very unpredictable, but I'm quite convinced that only surgery is not the answer for these extensive diseases. We need to find the right mix of chemotherapy, the right combination, the right dosing, and the you know sequence of chemotherapy to be given to these patients to get the maximum benefit. So I think we all have these kind of stories, which is, but your protocol, what does it entail? How many cycles before you decide? And then after exploration and resection, what has been the outcome in these patients?
So our protocol is, sir, we give 4 cycles. After 4 cycles, we repeat the imaging, and there would be 3 group of patients. So one is that disease is little bit progress.
Progress.
Second group is that disease is stable, not progress at all. Third group is there is a significant decrease in the. We are using PET scan, and if third group is very important because after 4 cycle it seems that there may be a chance that later on some disease might come. So after 4 cycle, we try to stop there, and if resectable disease, we go and try resection. If not, then we ask them to complete 8 cycles. We are targeting nowadays 8 cycles. If somehow patient because of any other reason a patient has not come back, they have completed 6 cycles, then come back. And then from them again we stop the chemotherapy and go and try to explore and see if that particular time is again resected, then again we go and complete 2 more cycles. We are not going to 12 cycles. There are some people who say we can give 6 more cycles. But I do, to my mind, it doesn't work so much of so many cycles usually not required to them.
You think you still need some, you know, changes or fine tuning of chemotherapy to the one which you are giving right now?
At this stage, with people were talking to me, James is this because of protocol that has come, but that publication is they have included hyaluronic maximum their patients are cholangiocarcinoma. So when I started giving chemotherapy, we started with Gemox, and we were satisfied. So I am not uh, at this stage. We are discussing many times, but we are still continuing with that.
So finally, TD, so much of thought has gone into managing these complex patients and all. But you've been saying that there's still a lot of work to be done. So can you outline two, three areas which need or your group is working on, which needs immediate attention, which you think may have immediate impact or clinical impact in these patients?
Sir, one area is like suspected diagnosis, like because we are finding that our negative biopsy coming as negative because of Jantho and IgG4 some rarely, but Jantho is important. Is our negative, but there is no tumor in the specimen. Chronic cholecystitis or Jantho has gone to in the tune of 20%. So I think that is very very important that we should select our patient little bit more. Something more to be done. And recently, Dr. Pankaj, I'm requesting them that even after CT scan, if there is a doubt, you make some GB rats so that we our this type of histopathology number get lesser. And the second important, I think, would be that can we somehow predict that we are the people who are going to respond that by doing lots of things are being done in pancreas and colorectal. So we have not been able to do any this type of genetic study in the gallbladder. I did some small studies, but KRAS also did, but the numbers are less, and this positivity rate is very less in gallbladder cancer.
No, I think the first point, because I often see that there is a big fear psychosis which is created amongst the clinicians that, you need to treat all these suspicious thick-walled gallbladder as gallbladder cancer and you've brought this point out that we need more information. It's like, a barber's chair phenomena that it comes to SGPGI or PGI and you say it is gallbladder cancer and just do a wedge and all. Of course, you may be able to do with less morbidity, but is it required?
But
So
this is the one thing is haunting me because my this rate is about 20%.
yes.
So it's not good at all. We should be 5 to 10%. Though there is no even there is no morbidity. It doesn't matter. Yes, sir.
So finally, the TD that we know uh, is a favorite of students, is a favorite of colleagues. If you have to give advice to young people who are embarking on a journey, what is your message to them that how you would advise them in terms of embarking on a career of a specialized surgical field?
You have asked this question. I think for me it's very important. One of my friends, his son of a doctor, he's neurologist by now, and I used to rarely talk to many because of some complexes of coming from Hindi background in medical medicine. I think I was in BTech also for the time being, but in medicine it's a phenomenal that if you are not spoken English is not good, you are not taken very this thing seriously
Seriously.
by any consultant. So it was in MBBS, never in MS. But I asked my friend, yeah, how should I improve my vocabulary English? Because my English grammar is I know very good. My teacher used to say in village schools also, but I am not able to catch the words. Then he said, yeah, you know, you do one thing. You start reading the editorials. So I used to ask the chowkidar of the that keep this paper for me in the evening. And in the night when everybody sleeps, I used to take dictionary and So I remember my first editorial in Times of India took 40 minutes, that is small editorial, to finish it, because so many words I had to go and check it in the dictionary. What is meaning of this? Still I do it. But just like I listen to you, I listen to doctor in SGPJ also. So some word, somebody says this word is looking good, but I don't know how to use it. So I will not tell anybody, but I go and see the dictionary. I used to keep many years, till many years. Still, I somewhere this dictionary is there, Oxford, and I used to say why this word, how this word should be used. So anybody coming from anywhere, I feel honesty to your profession, honesty to your teacher, honesty to your this patient. These are three H, which is the backbone of my profession, our profession. So if I am honest to my teacher, honest to my colleagues, and honest to my patient, these are the three important pillars. And in spite of the fact that nobody used to say anything to us in MBBS, but same T D Yadav in MS in the same medical college was the most popular person, I can say with guarantee. Teachers, and I think teachers and friends and patients. These are the three important pillars. For me, only teachers and friends have helped to come to this stage. And patient, obviously, honesty to the passionate toward the patient, and learning every time, thriving to learn. Whatever you get from something, take it. So I will take one good, this thing. One Tulsidas said very nice thing in Hindi, because you know good Hindi. So he said, "Simati simati jal bhar hi talawa." So when the drop of the this rain comes and they coalesce, then only they make a pond. If they go scattered, they cannot make a pond. So I tell our student also, whatever you pick it up, try to assimilate, and you should not get disheartened. You should push your effort, but God has given immense capacity to the human being. So we don't use our capacity. If they are honest, no need to do
But
all this.
these lessons are also important for everyone. It's not only
Yes.
for those people. I think what you said, that commitment, honesty, desire to learn, you're doing. I think those are virtues which each one of us need to develop. So it was great talking to you. I've thoroughly enjoyed it. Uh, More apart from the fact that you brought in some insights into the difficult problem of gallbladder cancer, I think the human side of TD Yadav is what is more endearing and uh, special to us. So thank you very much
Thanks
for
a lot.
being on
Thank
this.
you, sir.
And
Thanks a lot for giving this opportunity.